This will be a walkthrough of how to perform the full body musculoskeletal physical examination. In this video, we will be discussing tips and tricks on how to get comfortable while performing the full body musculoskeletal examination. Let's go ahead and get started. For the head portion of the musculoskeletal examination, first you will evaluate the temporomandibular joint, also known as the TMJ. To do this, go ahead and place your thumbs anterior to the tragus on both sides, and then go ahead and ask the patient to open and close their jaw. All right, good. Any pain with that at all? Pain or crepitus is a positive test for this. For the shoulder portion of the musculoskeletal examination, first you want to begin by undoing the patient's gown. So is it okay with you if I go ahead and undo your gown right here? And you want to go ahead and just expose their shoulders right here. And so first you want to begin with inspection of the shoulder, making sure that you're looking at the heights of both shoulders, as well as looking on the posterior aspect for any muscle atrophy or any winging scapula, which may indicate a tendon rupture or neurological problems. So next, you want to begin with palpating at the SC joint, the sternoclavicular joint. So first, go ahead and find the SC joint right here, which is a nice prominent bump on the middle of the chest. And then go ahead and trace the patient's clavicle right here until you reach a point to where the clavicle kind of comes up and forms a tip right here. And then go ahead and slide your finger until it falls off of that tip. And right there, you have your acromion and your AC joint, your acromioclavicular joint right there. And then from this position, go ahead and slide your thumb inferior and medially till you can feel a bony prominence right here, which is your coracoid process. So then what you want to do is go ahead and just place your hand directly on the outside of the patient's shoulder, on their deltoid, and your thumb should land around the patient's bicipital groove. So just kind of move your thumb around until you feel a nice like ropey tendinous structure. So right there, if you can kind of see that tendon moving right there. So that's the intertubercular groove right there. And you have your biceps tendon located within that. And then go ahead and just slightly slide your thumb laterally until you feel bony prominence, which is your gradient tubercle right there. And now you have the supraspinatus, the infraspinatus, and teres minor muscles, which come and insert right here. So from that position, then you want to just go ahead and palpate those muscles. So supraspinatus up here above the scapular spine. Then go ahead and just palpate the scapular spine, just palpate the scapula, and then just palpate the muscles inferiorly right here, which is the infraspinatus and teres minor muscles. For the shoulder range of motion, you want to begin by first assessing flexion. So what you want to do is just tell the patient to go ahead and relax their arm right here. So now just go ahead and raise your arm directly straight in front of you, up towards the ceiling. All right, perfect. So now go ahead and bring that back down. So now go ahead and bend your elbow like this for me. And now just swing your arm back. So this is extension right there. So now good, go ahead and relax. So now go ahead and raise your arm directly out towards the side, going as high as possible. So this is abduction. Good, so now go ahead and bring your arm up here for me. Now go ahead and turn your fist up so that way it's facing towards the ceiling. So that's external rotation right there. Good, relax that right there. So now go ahead and bring your hand behind your back for me. And now you want to go ahead and just slide your hand up as high up your back as possible. And that's shoulder internal rotation. Good, go ahead and relax. So for the elbow portion of the MSK evaluation, you want to begin by inspecting the elbow, looking for any swelling or any gross deformities, or for any discoloration. Next, you want to palpate by starting at the ulna. So go ahead and start palpating the ulna on the side of the wrist opposite to the thumb. So go ahead and just trace the ulnar shaft right here, which will then go ahead and turn into the olecranon process on the posterior aspect of the elbow. And now what you want to do is just go ahead and form a C shape right here and place that directly above the olecranon process. And your thumb should be right here on the lateral epicondyle, which you could see is a nice prominent bump right here. So land there. And then on the medial aspect of the elbow, your index finger should land on the medial epicondyle, which is this bony prominence right here. And then finally, to palpate the ulnar groove, just go ahead and slide your index finger slightly down, and you'll land in this nice notch right here, which contains the ulnar nerve. So next, for elbow range of motion, you want to go ahead and take the patient through a few ranges of motion. So first it will be flexion. So can you go ahead and just bend your elbow as much as possible for me? All right, good. So now go ahead and just fully straighten out your elbows right here. All right, good. So that's extension. For elbow pronation, you want to go ahead and tell the patient to bend their elbow and keep it tucked towards their side while you're doing this. So this is a neutral position of rotation. So now go ahead and pretend like you're holding a cup of soda. So now go ahead and pretend like you're pouring it out by turning your forearm in. Good, so that's pronation right there. Now return to the starting position. So now go ahead and turn your hand out as if you're holding a bowl of soup. So that's supination. So good, go ahead and relax. So remember, pronation is you're pouring out a can of soda, and then supination, you're holding a bowl of soup. For the wrist and hand portion of the musculoskeletal evaluation, first you want to begin by inspecting the wrist and hand, looking for any gross deformities and any signs of swelling, as well as any nodules located on the hands, which may be indicative of some pathologies. So for palpation of the wrist and hand, first you want to begin by palpating the patient's radius. So that's on the thumb side of the wrist right here. So just go and palpate the radius, and then go ahead and palpate the patient's ulna on the opposite side of the wrist. So now you want to palpate the anatomical snuff box, so go ahead and pull your thumb back for me. So the anatomical snuff box is created by these tendons, so go ahead and palpate within that, which has a scaphoid bone, so go ahead and relax. So then you want to palpate the remaining carpal bones, going along the carpal row. And then you want to go ahead and palpate the patient's MCP joints while using 2 fingers. So go ahead and just use 2 fingers and palpate the MCP joints right here. Good, so now you want to use 4 fingers to palpate the DIPs right here, and then the PIP joints right there. So go ahead and just form like a box with your 4 fingers and just palpate those. Any pain with that at all? All right, good. So now we'll be assessing the range of motion of the wrist and hand. So first we'll start off with the wrist flexion. So can you go ahead and make a fist for me? Good, so now turn your arm up, hand up like that. Good, so now go ahead and curl your wrist up for me. All right, good, so that's wrist flexion. So now go ahead and turn your wrist over. So now go ahead and curl it up for me. That's wrist extension. Go ahead and just relax your hand right here. So now go ahead and just slide it away from you towards the outside. Good, that's ulnar deviation. Now slide it towards you. Good, that's radial deviation. So now just go ahead and make a fist for me, bend your fingers. Good, that's finger flexion. Go ahead and straighten that out for me fully. That's finger extension. So now go ahead and spread your fingers as far apart as possible. So that's finger abduction. Now go ahead and bring them together and squeeze them together. And that's finger adduction. All right, good. You can go ahead and relax. For the hip musculoskeletal examination, you want to first begin with the patient lying supine, and you also want to make sure that you're pulling out the tray when you're actually doing the OSCE. So first, you're going to go ahead and start off by inspecting the hips, but you just want to verbalize that you'll be doing that. Next, you also want to verbalize that you'll be palpating the hips, but again, you won't be actually doing that during the OSCE. So for the range of motion assessment, you want to start off by having the patient do active flexion. So can you go ahead and bend your knee and hip up so that way you're trying to touch your knee to your chest? All right, perfect. So now go ahead and straighten that back out. So if the patient has limited active range of motion, you can then go ahead and put them into hip flexion. So put one hand on their lower leg and one underneath their thigh, and then go ahead and just try to touch their knee as far as possible towards their chest. So next, for hip abduction, you want to go ahead and place one hand on their opposite lower leg to help stabilize it. And then with your other hand, go ahead and place that around the patient's lower leg. And now go ahead and just slowly slide that away from the midline until you start to feel some resistance. And then that's their hip abduction. Next, for hip adduction, again, go ahead and stabilize the other leg. And then go ahead and just slightly lift this leg up and bring it across their midline right here, going as far as possible. And once you feel some resistance, then go ahead and stop and slowly bring it back to the starting position. Next, you want to evaluate hip internal and external rotation. So go ahead and place one hand on the patient's lower leg and then another underneath their thigh, and go ahead and bring their hip and knee into 90 degrees of flexion like this. Next, you want to go ahead and just switch your hand positioning so that way it's nice and comfortable. So this is a neutral position for rotation. To go into external rotation, what you want to do is go ahead and swing the lower leg in, which will cause the knee to go out. So this is hip external rotation. And now to check hip internal rotation, go ahead and swing the lower leg out, which will cause the knee to go in. And that's hip internal rotation. So when you're doing internal rotation, in external rotation, one thing that's important is that whichever direction that the knee is going in, that's the direction of hip rotation. So again, if your hip is going in, that's internal, or your knee is going in, that's internal rotation. If your knee is going out, that's external rotation. And now can you go ahead and switch over to being on your stomach? So now for hip extension, what you're going to be doing is just ask the patient to keep their knee straight and lift their leg straight up towards the ceiling. Perfect. Now go ahead and lower that. If you have any limitations in the active hip extension, go ahead and place one hand underneath their thigh and one underneath their lower leg. And now just go ahead and slowly lift that straight up. And then go ahead and bring that back down. And that's your range of motion for the hip. For evaluation of the knee, first you're going to go ahead and start off by inspecting it. You want to be looking for any gross deformities. You want to note the alignment of the patella. And additionally, you want to be looking for any signs of effusion, especially loss of the dimples on the knee, right here and here, which will let you know that you may have a knee effusion. And finally, you want to be looking at the quadriceps muscle and compare bilaterally to see if you see any atrophy. For palpation of the knee, you want to go in a systematic approach, moving from a proximal to a distal approach. So first, go ahead and palpate the patient's quadriceps tendon right here. And then go ahead and palpate their patella. And then their patellar tendon right underneath the patella. And then you have your tibial tuberosity right here. So next, go ahead and bend the patient's knee to about 90 degrees right here. So what you want to do is go ahead and make a C shape with your hand and go ahead and place the C part right here, right underneath the patient's patella. By doing this, your index finger should land right here on the medial joint line, and your thumb should land here on the lateral joint line. And to know that you're in the joint line itself, you should feel two prominent bumps on the sides of both of your fingers, which would be the femoral condyle and tibial condyles. But again, you just want to make sure that you're in the right spot, that you're actually on the joint line. And on the medial side right here, you have your medial meniscus, and then you can also palpate your MCL, which goes from your medial femoral condyle down to your medial tibial plateau. And then on the lateral aspect, you should feel the lateral meniscus as well as your LCL, which runs from your lateral femoral condyle down to your fibular head right here. So you may feel that ropey structure right there. Also for palpation, you want to palpate the posterior aspect of the knee right here, back in the popliteal fossa, checking to see if the patient has a Baker cyst. All right, good. So go ahead and straighten out your knee right here. So now you want to go ahead and assess range of motion. So first you want to do flexion. So go ahead and just bend your knee as much as possible. All right, good. So now have your foot down right there. All right, perfect. So that's flexion. So you can go ahead and relax that. And if the patient has limited flexion, you could do it passively by placing one hand on the lower leg, and then just go ahead and just slide that right there to assess flexion. All right, good. So now to assess extension, you want to just place one hand on the patient's thigh and one underneath the lower leg, and go ahead and just, while stabilizing your hand right here, go ahead and just pull the lower leg up like this to assess this extension and hyperextension right here, and then go ahead and relax. For the foot and ankle portion of the musculoskeletal examination, first you want to begin by inspecting the patient's foot and ankle, looking for any gross deformities or any signs of swelling, as well as calluses or a bunion on the first digit. Next, for palpation, begin by palpating the patient's fibular head, which is on the lateral aspect of the knee. Then go ahead and trace the perineal muscles located on the lateral aspect of the lower leg. And then go ahead and palpate the patient's medial malleolus, which is the most prominent bump on the inside of the foot and ankle right here. And then go ahead and palpate the patient's lateral malleolus, which is the most prominent bump on the outside of the ankle right here. Next, you want to go ahead and just slide your thumb down and in, which will lead you into a divot right here, known as the sinus tarsi, which contains the anterior talofibular ligament. So next, you want to go ahead and palpate the patient's Achilles, which is right back here, which is a ropey tendinous structure that comes and then inserts onto the calcaneus. So go ahead and palpate the calcaneus. And then you want to just go ahead and palpate the inferior portion of the calcaneus down right here by your calcaneal tubercle. Finally, for palpation, you want to go ahead and palpate the MTP joints with 2 fingers. So the MTPs are located right here. So just go ahead and just squeeze each MTP right here, assessing for any tenderness or warmth or swelling. Finally, you want to assess the foot and ankle range of motion. So first begin by assessing dorsiflexion. So go ahead and ask the patient to pull your toes up as if you're trying to touch your nose. All right, good, now relax. And now ask the patient to go and push down as if they're pushing on a gas pedal. And that's plantar flexion. So now ask the patient to turn their foot and ankle in, so that way the sole of their foot is facing the other side. Good, and that's inversion. And go ahead and ask the patient to turn the foot and ankle out, away from their opposite foot, and that's eversion. For the cervical spine portion of the musculoskeletal examination, begin by inspecting the patient's head and neck position, as well as the heights of their shoulders, looking for any muscle spasm around the neck. Next, for palpation, ask the patient to bend their neck slightly. So can you just go and bend it a little bit? And then you should see the spinous processes of C7 stick out right here. So it's the most prominent cervical spinous process. So go ahead and palpate that, and then palpate the spinous processes moving superiorly. After that, then go ahead and palpate the paravertebral areas, the muscles along here. Any pain with that at all?
No.
All right, good. And then just go ahead and palpate the trapezius muscles. Any pain with that?
No.
All right, perfect. So now we'll be assessing range of motion. So first, for cervical flexion, can you go ahead and try to touch your chin down to your chest for me? All right, good. So now go ahead and look up at the ceiling for me. This is cervical extension. So now can you go ahead and try to touch your right ear to your right shoulder? All right, perfect. And now your left ear to your left shoulder. All right, good. So that's lateral flexion for the neck. And now can you go ahead and just turn your chin towards your right? All right, good. Now turn towards your left shoulder. Turn and look over your left shoulder. All right, perfect. So that's cervical rotation. So that's range of motion for the cervical spine. Next, to evaluate the full spine, you want to go ahead and undo the patient's gown. Is it okay if I take the gown off here in the back? All right, perfect. So now can I just have you go ahead and stand up for me, please? All right. So now I'm just going to go ahead and expose the patient's lower back. All right. So now I'm going to go ahead and inspect the rest of the back, the thoracic and lumbar spine as well right here, noting for the positioning. So now I'm going to go ahead and just palpate the patient's spinous processes. So I'm going to go ahead and start from C7 up here and then work my way down. Any pain along here?
No.
All right, good. So now I'm just going to go ahead and palpate the paravertebral areas. Any pain right here?
No.
All right, good. So now I'm going to just have you go ahead and can you, for range of motion, can you just go ahead and bend your toe, bend down and touch your toes for me? All right, good. And so now I'm looking for any curvature at the back and to see how far they go for flexion. So now can you go ahead and put your hands on your hips for me? And now within your level of comfort, go ahead and lean back. All right, good. Now relax. All right, and again, you want to make sure that you're really stabilizing the patient and being there in case if they start to lose their balance. So now to assess lateral flexion, so can you just go ahead and step over here for me a little bit? All right, perfect, and you can turn it back that way. So now with your left hand, if you can just go ahead and slide that as far down your left leg as possible. All right, good. So now same thing on the right side. All right, perfect. And so now can you go ahead and just cross your arms across your chest right here? So now can you turn towards your left for me? All right, good. And now towards your right. All right, good, and relax. And that's range of motion for the spine.
Thank you for watching this video walking you through how to perform the full body musculoskeletal physical examination.